All right, well, welcome. Good morning. We have with us today Dr. Neel Shah. I'm so excited to talk to you today, Neel. We are continuing the conversation as a result of that very in-depth USA Today story that we saw come out on the 27th of July. We are really having this entire series of conversations as kind of a look behind the headlines, beyond the headlines, and be making childbirth safer, and what are some of the solutions that we can start exploring. I think we've done, media has really supported this initiative in doing an excellent job in exposing the problem and really underscoring the depth and breadth of it. And really what we want to do now is dive into, okay, so what can we do about this? Mm-hmm. So with us today is Dr. Neel Shah. Very excited to have you. Dr. Neel Shah is the assistant professor of OBGYN at Harvard Medical School. He's also a practicing OB at Beth Israel Deaconess Center in Boston. So comes at this both through a clinical lens as well as a research lens, and
as a parent.
And as a parent, let's not forget that. That actually adds a critical component to the understanding and empathy of what we go through as patients. So let's talk about, number one, you had a really provocative, interesting Twitter thread that followed this article, and I want to kind of pick up on some themes in there. You talked about that there are failures in the healthcare system, usually for one of two reasons: ignorance, which is lack of knowledge of what should be done, or ineptitude, which is the failure to execute on the knowledge that we already have. And then your conversation kind of leads us to this place of, it really has more to do with, why do we have ineptitude then? But I want to take one step back and actually challenge the ignorance or lack of knowledge, because while we know that healthcare providers, no one goes into this for wanting to harm patients. Everyone goes into this absolutely with the right intentions. But over time, knowledge can change, and we sometimes get stuck in our old ways of doing things. And as patients, I can tell you, we often see examples of things like nurses not taking blood pressure correctly. And that is such a fundamental data point for treating preeclampsia, that the lack of knowledge of how to take a blood pressure measurement, as an example, is something that does still persist and needs to be explained and corrected. And for some people, maybe they learned one way and it's evolved over time. Other things that we see that I think probably represent that lack of knowledge would be using magnesium sulfate as a treatment for hypertension. Magnesium sulfate is a drug, very important drug to prevent seizures, but erroneously is sometimes seen as an antihypertensive. And there are other instances like that. And so a lot of the bundles or protocols that have been created were created because we've seen these failures in all the data analysis around maternal mortality and a lot of morbidity. So before we get into what do we need to do to fix systems, I'm wondering if you can comment on, are there better ways to improve knowledge that we aren't perhaps doing today or aren't doing universally?
Well, that's a great question. And let me just first by thanking you, Eleni, for having me to talk about this really important subject. And I definitely want to answer that question, but I want to step back for 1 second and just explain where I'm coming from in probably everything I'm going to say, which is that even though prosperity has grown for the average American over the last generation, the prospect for any American who wants to start or grow their family is a riskier proposition than it was for their own parents today. That's insane, right? I mean, just over the last generation, it's become 50% more likely that an American is going to die in childbirth. For every death, there's 100 life-threatening injuries, as you know well. And for every one of these life-threatening injuries, there's tens of thousands who experience avoidable suffering because of a physical or mental illness that we don't adequately respond to, because of professional disruption, because we don't have paid family leave, or because of general social disempowerment, let's say, because we assume that moms are not capable of doing all the things that they are. And along the way, the only way this is possible to have this disconnect between prosperity and risk and starting or growing your family, which is one of the most fundamental things that we do, is that it's an insidious and largely invisible problem. And, part of the challenge is that moms are very good at advocating for social progress for everything except for their own well-being. You actually are an exception to that rule. I think you're one of the first people out there who, as a mom herself, really started to advocate on behalf of all moms. And so it's part of why it's an honor to have this conversation with you. And I think it is a big part of where I'm coming from in thinking this through, because although knowledge is absolutely key, and knowledge is also tricky because most people who are working in the trenches don't know what they don't know, right? It can't be the comprehensive solution. And that's really all I'm trying to say. I think that there are definite examples of incompetence. That being said, I think there are really good channels for trying to address incompetence. And if that was the total solution, we wouldn't be seeing this huge disconnect between growth and prosperity and erosion of the safety of giving birth over the last generation. I think there's a missing component of it, which is what I'm hoping that we're going to get into, which is really the ineptitude piece. Yes. So I totally agree with you. Like, there's many ways of fixing education. And I think that our professional societies do a great job of trying to steer the professions around the state of the science. It's what ACOG does. It's what A1 does, the nurses. It's what the midwives do. And there's always room to do a better job of making sure that knowledge gets all the way out into our communities. But I don't think it's the full solution, because even really well-informed people fail.
Sure. So before we get into some of that piece of it, there's been a lot of talk about the bundles that have been created, and specifically there is one for hypertension and pregnancy. Do you think that the bundles are one component of making sure that knowledge is sort of universally understood and given kind of a platform for communicating it out? Do you think?
Yes, although I've been critical of bundles. So let me explain myself, because I think that bundles are very important. But again, I just, maybe it's my personality, but I always see the nuance. And just for your audience to be clear, so what bundles are these sweeping, comprehensive, usually documents that go through all the things that we could be doing to address some critical problem, whether it's hemorrhage or hypertension or another problem. And what they do, and what they do brilliantly, is they bring together thought leaders from across the professions, often involving patients as well. And they literally think through all the different things that we could be doing to address it, and they put it in one place so that everybody can see them. And I think that's a really, really important step. The challenge, though, is I think that, sometimes people think that simply by telling people to do something, they're going to do it. And I think
children know that's not true.
Right. And I think that what's been hard about the bundles is that they're so comprehensive, which is also their strength, that they're really, really hard on the front lines to interpret, because they come across as these long laundry lists of what people ought to do. And usually the way that they're rolled out, they're sort of like, they're handed off, and the hospital that's in Tulsa, Oklahoma, or Sioux Falls, South Dakota, or Lake in Kansas, like the middle of nowhere, really, is told, of these many things that you could do, pick the ones that you think are the most applicable to you. And what we're not doing is helping those hospitals navigate, well, what are the things that are actually likely to be the most impactful? And how do we design the processes in enacting those things so that they're actually feasible? Because it's often where the rubber hits the road. I think there are many examples of cases where people are very well intended and very well informed, but again, fail because the systems around them are so complicated.
Sure. So let's talk about that a second. Let's shift over to sort of the other part of that formula, and putting aside for a second the knowledge base, let's assume for a second that people know what they should be doing, and then it's a matter of execution. And is the execution not happening because of ineptitude or because of other barriers? What are those barriers? What are preventing good people, knowledgeable people in the healthcare profession from doing what we know to be the right thing to do?
Well, if you think about it, most moms who experience labor do so, 99% of American mothers deliver their babies in hospitals. And what you see are the four walls of the room where you labor and give birth. And you assume that the care that you're receiving depends primarily on what's happening within those four walls of your room. But the truth is that that care depends equally on what's happening outside those four walls. And we've got really good evidence of this, actually, where the number of other women laboring simultaneously is one of the most significant risk factors for everything that we care about, from a hypertensive emergency to hemorrhage to your odds of getting a C-section to your odds of other types of injuries. And so that, I think, to me, reflects the complexity of the system, which is, if you think about it, people who are staffing a labor floor have no idea how many women are going to go into labor that day. Like, if there's a full moon, they assume they're going to be busy. That's really all they know. You don't really know how long each woman is going to be in labor. And you don't know which one of those women is going to become suddenly sick enough to need some critical resource, like the blood bank or the operating room. And the people who are managing it are sort of constantly dynamically shuffling resources, whether it's nursing staff or beds, almost like an air traffic controller. Mm-hmm. But it turns out the job of
air traffic controller, those flights are all scheduled.
well, things happen in flight too. I mean, there's anybody who's been held on the tarmac, there's weather, there's mechanical failures. But the main difference between being the nurse in charge of a labor and delivery unit and being in the air traffic control tower, and I've actually gone to the air traffic control towers and done a head-on-head comparison, is that first, the air traffic control towers are much better resourced. There's never one person managing the amount of complexity that it takes to land planes safely, because it would be unsafe to have one person doing it. Yet that's exactly what happens on the labor floor. And there are all different ways that air traffic controllers or even restaurant managers who have the same problem of, like, when are my customers going to show up? How long are they going to be staying at their table? What ingredients do I need to get based on the uncertainty over what people are going to order? There are all kinds of tools that hotels, restaurants, and airports use that we really just sort of don't on labor and delivery units. We're under-resourced and we just sort of react to challenges on the fly rather than planning for them. So those are the kinds of systems that I'm talking about that I think are missing and are part of the solution.
Mm-hmm. So what could that, I mean, you're known for innovation. That's sort of your unique lens that you look at this issue. What potential innovation could we see in a field that has largely remained unchanged for 50 or more years?
Eleni, I mean, well, we can go back, let's say, a century. Actually, I think every century there's some large update to how we think about the systems for one of the most core services that we do as a healthcare delivery system, which is supporting people through birth. The last update was like 1912, when we decided that rather than thinking about childbirth as a sort of natural process, so that we would apply the same lens to childbirth that we do for diseases, really. And that basic philosophy led to the average labor and delivery unit looking largely like an ICU. I think this is really important. So, what defines an ICU is not a ventilator. When people think of an ICU, they often think of people who have like a breathing tube, but the actual definition of an ICU is the ability to staff one nurse to one patient. And the cardiac ICU does that, and so does the labor and delivery floor. The cardiac ICU monitors vital signs in real time with heart rate monitors. So does the labor and delivery unit. The cardiac ICU titrates medicine on a minute-to-minute basis, meaning like every minute they'll adjust a dose. So does the labor floor every single time they give somebody oxytocin. The only difference between the labor and delivery unit and the ICU is that our operating rooms are actually attached. What that means is we have the most intense treatment area of the entire hospital for what are fundamentally the healthiest patients. And when you think about it that way, you start to see a system of enormous complexity where any reasonable human being could fail. Because there are, every time we have a new idea in labor and delivery, we sort of deploy it without a system. My example of this is on my labor and delivery unit. If you were to walk into any one of the rooms and look to the left, like the head wall opposite the mom's head wall, there are 7 different garbage cans because we have 7 different ways of throwing things away. There's a Sharps container, There's a biohazard bag. There's a recycling bin. There's a normal garbage. There's a soiled linen thing. There's a sterilization tray. I mean, it's crazy. And the problem with operating that way is that every single time you have a new idea, you create more decisions and more options and fundamentally more ways that people can mess up.
So to use that example, and I realize you're giving that just as one example, through your lens, is the solution to throw everything in one garbage?
Sure. I mean, or at least make sure that, however you sort things happen on the back end. It's not the clinician who's also trying to figure out how to manage, or let alone not even a crisis, but just to support a woman in labor. What we often forget is that every woman deserves support and coaching and monitoring in labor. Many women also benefit from medicine, and a few of us benefit from surgery. But we end up getting so focused on the sharp end of it that we forget to do some of the basics, like just supporting women in labor. And if you're trying to figure out which garbage can to throw the thing away in, it's one of many, many things. It's one of the most mundane. Now, the counterexample to that is trying to figure out, this is how you start to think about how to simplify. Because if you think about it, in every other domain of our lives, from the way we get around, the way we put food on the table, to the way we communicate, science has fundamentally simplified the way that we do things. We don't have to go and most of us don't farm our own food, but science always seems to complicate our lives in healthcare. And the reason is that we don't make it a goal to simplify. So if we were to do that, one of the ways that I think about a lot of what ails us in childbirth is that there are a lot of, the fundamental problem is that we're inaccurate at deciding when to act. That's usually what it boils down to. Either we act with too little too late or with too much too soon. That's it. And if you think about the problem as a failure of timing, you sort of realize that there are two types of timing issues. One is responding to emergencies. And I would actually argue that in almost all cases, we have total clarity about when to respond to an active emergency. But where a lot of the failure happens and where a lot of the injuries and suffering happens is acting to prevent an emergency in the first place.
I was just going to say, it's once you're at that critical point, the question is, why did you have to get to that critical point? And it's because decisions weren't made before that. That's
exactly right. And people will disagree from now until the end of time about when to act to prevent an emergency. And I actually think that's okay, because there's a lot about obstetrics that's sort of an artisanal craft. But what you want to make sure is that when you've got really well-trained artisans, which is what obstetricians like me kind of are still in 2018, that they're making decisions with all of the information available. And right now, that information lives in the brain of multiple people. It lives in the brain of the mom herself, primarily, who can not only tell you what her symptoms are, but things that aren't really symptoms, like how much energy she has to push, let alone her preferences for how she wants to be cared for. Then you've got the nurse who spends more time at the bedside than any other care provider. And then you've got the delivering provider at minimum. And right now what we lack is a way for all three of those actors to efficiently share the information that they have in an organized way. And to do that, you've got to define, during every labor assessment, what are the things that we ought to do for every woman every time? And nobody has defined that, although it's extremely simple to do. But if I go to my residents who spend 100 hours a week taking care of laboring women and ask them, what are the things that you ought to do for every woman every time? They'll get there, but they don't have a way of rattling it off in an organized way.
So is that a checklist? I mean, let me do this. I'm going to turn this around and challenge you to simplify the solution. I realize that, this is, you're unraveling a complex problem. In as simple as phrase or sentence as possible, what is the solution to bringing together all needed information in one place so that the decisions can be made optimally?
Well, you need two things. To get to accuracy, if you're engineering a system, you need precision and you need reliability. And right now we lack both. So the precision problem first. When we go and assess any woman in labor, we're always doing three things every time. We're assessing the mom, we're assessing the fetus, her baby, and we're assessing the progress of labor. And those are three different distinct things that we conflate all the time at the highest levels. At the editorial table of the New England Journal, these three things get conflated. And the best example of this is that a high-risk pregnancy and a high-risk labor are not the same thing. They're not even necessarily related, but they're all increasing numbers of women who arrive on labor floors with a high-risk pregnancy. And then we forget that having a high-risk pregnancy is not the same thing. Like, you can have hypertension and actually labor normally. And that might even be the safest thing for you, is to allow you the opportunity to labor normally. So that's the first problem. The second problem is reliability, which is the problem often is not that we don't know what to do, it's that we don't do it reliably for every person every time. Like with the surgical safety checklist, everything that's on it is very obvious to the average surgeon that these are things that we should do. But the difference between thinking that we're doing them and actually doing them drops mortality in half for every surgery on every continent. And after the smallpox vaccine, the WHO thinks it's the most impactful thing they've ever done. And our equivalent of that, we think, and it's something we're testing right now. I mean, this is a theory. I don't have all the answers. I fully...
Okay, this is the theoretical conversation, because obviously it's not all being done yet.
No, but it will, and we're going to fix it all, Eleni. But it's not a checklist in labor and delivery, because a checklist requires a natural pause point. So a natural pause point, like before a pilot hits the throttle, that's when you run the checklist. For a surgeon, it's before you pick up the scalpel. Labor and delivery just goes, man. Yeah. So you can construct a pause point, and there are moments where we ought to do that before we bring a woman back for a C-section or we do a procedure. You need a different type of system to ensure reliability. And so ours is, we've created like a totally simple 4-quadrant whiteboard. It's analog, and it lives in the woman's room, and it takes the 4 things that should happen for every woman every time. And it's big, so everyone can see it. It's simple enough that everyone in the room, particularly the mom, can understand it and be a driving participant. And it uses the same principles of the checklist. So the first quadrant is just to name every member of the team. That's it. And name the mom as a member of the team. And the first step in the surgical safety checklist is for everybody to introduce themselves. It's so silly. But what that does is it tells you people's names, which is nice. But what it really does is it creates both the permission and the opportunity to say something later on if something needs to be shared. The second quadrant is where the mom's, the information that only the mom has lives. Her preferences, her symptoms, things like that. The third quadrant is the plan, but the plan is itemized by mom, baby, labor progress. It's 3 different things. Mm-hmm. And then the fourth is so that the mom doesn't feel like, you know, a passenger on a plane held on the tarmac with no idea what's going on, where we preview what we think the next time when we're going to get together and talk about the plan. That's it. And just by doing those 4 things, we're early in the process anecdotally, but it seems to be creating much higher performing teams. Because right now the team for every woman in labor comes together randomly for every woman every time. Mm-hmm. You don't know which nurse you're going to get assigned. You don't know which doc you're going to get. Certainly as the doctor, you don't know which mom is going to come in labor. And you very quickly have to become a high performing team for one of the most important things in our lives. So that's sort of where we're focusing right now, is just trying to make them good teams.
So what I love about that is that you have clearly put the patient on that board. You know, as you said, she's not just a passenger on a plane, and I don't want to say unwilling passenger, but a, you know, just, as I say, bring us to the table, don't just put us on the menu. And so I guess a question would be, what can we as a patient advocacy organization help empower or equip women with to be active participants in that process that you just described? What would you like to, you know, if you could wave your magic wand and say, okay, if I could fix my system, this is what I would do. If I could help women be more effective contributors to this process, what would that be? What would that look like?
I think that fundamentally it comes down to empowerment, you know, because, I mean, I think the first thing is to know that pregnancy is like your body's first physiologic stress test for most women. You know, most women who are getting pregnant are fundamentally young and healthy, but then, you know, their blood volume increases, their lung volume decreases. A lot of women, we end up unmasking things like hypertension and diabetes for the first time. And there's so much about the way that we currently approach it that can actually be disempowering. I think, you know, a big part of it is being a participant in your care, but also realizing, you know, for example, birth and death are life's only two certainties. And we've institutionalized both relatively recently. And we've messed up both in very similar ways. But I actually think that our innovation at the end of life is starting to outpace our innovation at the beginning of life. A living will and a birth plan are basically the same thing. Only a living will, there's a system around it where it's well understood and it's respected. Whereas a birth plan, like, there's not really a system. There's not a lot of guidance out there. And then when people walk in with a birth plan, they're not always received very well. So I think part of it is, like, doing the due diligence and really trying to work with your provider to think through what your preferences are. Realizing that you deserve more than coming out of the process unscathed, right? That's the floor. We should be aiming for the ceiling, which is coming out of it supported and empowered. And then also, being flexible and realizing that, as you go through the course of labor, you don't always have to be driving. You might not want to, especially if you're in active labor and in the zone or you're pushing, that's fine. But having, being able to defer when that's appropriate too. But that doesn't mean that it's all or none.
Mm-hmm. Well, one of the things that you pointed out with your 4-quadrant concept was the idea that there is a quadrant of where the information is really what lives within the patient and her knowledge and understanding and recognition of symptoms that she might be experiencing. So at a really fundamental level, and something that we're passionate about at the Preeclampsia Foundation, is making sure that symptom education is part of her prenatal care, and an understanding and a recognition of what should you be calling out. A lot of women intuitively are going to just say, I've just got to suck this up and deal with it. This must be part of pregnancy.
Yes.
So there is a very deliberate patient education strategy that we believe in. I don't know if you want to react to that or how you feel about that.
Only to reflect it back and amplify it, Eleni. I think you're exactly right. And I think that this is just a thing. People will procreate whether we give them a dignified and safe way of doing it or not. And there's a real, kind of suck it up phenomenon that happens really throughout motherhood. Moms fundamentally put themselves last to put their families first. And it's not just during pregnancy and birth. It's actually one of my big concerns, and I'm sure it's true for you too, is this postpartum period where women leave the healthcare system. They're basically detached for 6 weeks until a short 15-minute postpartum visit. And all of the morbidity and mortality that we're seeing, the plurality, the majority of it happens in that window. And the only way to save those women's lives is for either them or their family members to express their concerns and have good insight into the symptoms. That was a key component of the reporting as well. And so what you just laid out as a strategy is absolutely critical. We have to give women the vocabulary, as well as the permission, honestly, to look after their own well-being as well as their babies.
Yeah, absolutely. Well, we are quickly running out of time here, and this has been fascinating. I think you've got a lot of really exciting ideas for us to be looking out for and to be participating in that conversation with you. And what I really applaud is that you clearly are involving patients in that conversation and recognizing, as we often say, that when we look at these systems, for improving the systems, you've got to bring the patient. She's the one person who's at the center of everything that's happening, whether she realizes it or whether the providers all realize it. So I really applaud you for doing that so profoundly. So thank you very much. We've been talking to Neel Shah, Dr. Neel Shah, for continuing our Behind the Headlines conversation. Thank you for joining us. We are going to be talking to other providers, patients, continuing the conversation. And I want to just point out to you that kind of keeping in line with this patient centricity, we have developed a preeclampsia patient's Bill of Rights that does sort of call out what are some of those key things that we as preeclampsia patients should be expecting from our healthcare providers. Again, it's not necessarily on us to be holding them to be informing them, but it is something that we can feel empowered to help keep them accountable. And if we're seeing things that don't feel right or don't look right, raising our hand and challenging that is completely within the realm of not just okay, but supported. So check out our Preeclampsia Patients Bill of Rights and stick with us as we continue the conversation beyond the headlines. Thank you so much.
Thank you.